Like that? Like, dang.
Is that her tag list?
No, that's her first one.
Oh, this girl. She said, copate.
You know what that means?
No, C translation. I don't know what I'm doing.
Same girl.
There's 6'8".
She's like a model. She has to be like a model.
Oh my god, I know.
She even has the height for everything.
The apprenticeship though starts out at $23 an hour. So,
2377.
yep.
She's so aesthetic.
No, like everything is perfect.
I'm about to restart my whole Instagram page. I don't care.
That's so funny.
Semesters below.
Say, I will accept, on the application, I'll say, what is your acceptable range?
I know.
378.
Speechless.
I will not accept 77. Yeah. That's funny.
A family from Sweden believes healthcare provided in Utah can save their child's life.
I love it when you go out and do photos.
Dude, that one girl, I was like, you are so stupid. Shut up. She's from Moab. I know. I'm like,
My fingers?
I'm like,
I don't
dude,
have to interview for
Like,
it.
stop.
Yeah, I just have to
Yeah,
apply
like-
for the license.
you couldn't have looked at, you really said the first polio vaccine. Like, you think 1978 they can make a COVID vaccine? You really think that?
I was very in shock.
And then one of my old high school teachers that she also had, what was it?
All right, let's go ahead and get started. How is everybody doing this morning?
Good, how are you?
Super awesome. Yeah.
So we like wrote this
Oh, after
Let's see.
I didn't even bother reading. I was like, I'm not even done.
Any
No, there's a
questions,
Yeah, he's one
concerns
of our teachers.
over
He's actually
anything
good.
or
I
everything
didn't bother
going
reading. I was
on?
like, no, he's probably fighting her.
No,
No.
he's really smart.
We just have one medication presentation today.
He looks like
Please give Rylan all your attention. After that, we'll take a quick break and then we'll get started with the slides for today. So, Rylan, take it away.
Yeah, he always
Nice.
like if I post something.
Okay, I don't know how to say
Great
this.
job.
How do you say that?
Like,
A torvastatin.
A torvastatin or Lipitor. I'm sure lots of you have heard Lipitor. Have you heard Lipitor before? No? Commercials about it all the time. Okay. There it is.
I don't want to
Lipitor.
be enough for him.
It is an lipidemic. Basically just means that it is a lipid-lowering medication. And they use it for coronary artery disease.
So cholesterol. It's a cholesterol.
Yeah, cholesterol stuff. So indications is if you have like coronary artery disease and it kind of affects the cardiovascular system, you know, all of that. So that's why you would need it.
Nice.
Okay, contraindications if you have active liver disease, hypersensitivity to anything within the product, obviously. Nursing mothers, if you have an elevation of your serum transaminase, and they don't know why, then you probably shouldn't take it. Women who are pregnant or become pregnant, it can cause fetal harm, so don't take it. And then, of course, if you're taking these other drugs that have cool names, posaconazole and ritonavir, I don't know, something like that, then don't take it.
Those are just antibiotics.
Oh, cool. Okay. There's your dosage. Actually, how that changed, I don't know. It's actually, you do, I didn't save it, but 10 to 20 daily. And then if you have elevation in something, then you should start taking more.
So it comes as low as a 10 milligram tablet, but it does go all the way up to an 80 milligram tablet. So if you see on your patient's med list that they have a torvastatin, it'll be listed as a generic. Just know that they do have some high cholesterol, triglyceride levels, which can affect their heart function, and so depending on how high the dosing is, will let you kind of give you a rough indication of how much they suck at dieting and eating appropriately, and therefore that also affects how well their heart is functioning.
And here's some great side effects. So diarrhea, that's a great one. These cool words that just mean joint pain and muscle pain. You can have a UTI, you can have nasopharyngitis, pain in your extremities, a rare disease that causes muscle inflammation and skin rash. That's what this is. And then liver failure, and then all of this too, especially systemic lupus erythematosus, which, as you can see, is immune system gets attacked, and your tissues, causes widespread inflammation and damage to all the affected organs. And it also affects your joints, skin, brain, lungs, kidneys, and blood vessels. So that's kind of scary. And then your hemorrhagic cerebral infarction. Not fun. So if you have these side effects, notify your doctor immediately.
Good job. Any questions for our RT talking to us today about cholesterol meds? Bueller?
It's been a pleasure working with you. Thank you.
All right. I know this isn't necessarily directly respiratory therapy related, but I was trying to throw something out there out of the norm. Will you see and hear a lot of patients on this medication? Yes. So this is just FYI for your information. But yeah, Lipitor, atorvastatin, simvastatin, rosuvastatin. Those are all referred to as the statins. When Rylan had mentioned, let's see, pain in the extremities. So one of the biggest side effects with these class of medications, these are like the go-to first line medications for high triglycerides and bad cholesterol, but they carry the potential for cramping. And so one statin might cause it and one might not for a particular patient. The biggest concern with these types of medication is a condition called rhabdomyolysis. So that's actually, when they take it, the cramping is a concern, but if it lasts for an extended period of time, it actually means that rhabdo is kicked in, and so it's causing their muscles to break down in a harsh and abnormal way. So that would be one of those, like another contraindication for this type of medication. But like I said, you'll commonly see it. You'll have tons of patients on it. So just try when you can. If you do have to go through our patient's med list, just try to reinforce, hey, make sure you're taking your maintenance medications, because this will help paint a better overall picture of their healthcare. Questions? Concerns? Okay, good job. Before we get started, any questions or anything going on, anything new or exciting with you guys? How's rotations going? You guys are doing rotations already, yeah? Does anybody have an experience or anything they would like to share before we get started?
I had a rookie mistake yesterday.
It's better, it's good to learn from your mistakes, but it's better to learn from other people's mistakes. So
I now
if you would like to share, we would love to hear your rookie mistake.
I just forgot to turn on the oxygen.
When they were bagging, right?
They were gonna start giving her oxygen. He's like, "Can you turn it on?" I was like, "Yeah," and I thought I did, but obviously I didn't. But
was that one of those, the saturation levels weren't going up, and they're just like, "Hey, that in all honesty, it's in the heat of the moment.
Yeah.
It can happen, So
it was like 5 seconds.
So I coach my kids' football team, so we always tell them practice makes perfect. So as students, as you guys gain more experience, it'll help, and things like that. Going forward, everybody will now know, hey, if I'm asked to turn on the O2 or if I'm asked to help bag, you want to make sure that the oxygen is on. Okay, that's why when I don't know if it's still that way, the O2 meters have the little ball that floats when you turn it on, so that's like a visual indication because
It was dark.
It was dark.
It was dark in there.
it was dark. Okay, next time turn on the light, turn it on when you're back. So no, but that's a good experience, okay? Because that's stuff that will not only help you, but it'll also help your class. Like I said, I walked into a patient's room one time and they had passed away, but nobody had told me because I was doing O2 rounds, and so I walked in, I didn't freak out, I calmly closed the door, backed away, went to the nurse's station and just asked them, hey, what's going on with, 102? They're like, ooh, yeah, they passed away. I was like, okay, that's what I thought.
It had a pulse, I just wanted to check.
Yeah, I just wanted to check, because normally, they'll kind of make some indication or let everybody know, because I guarantee you, if they don't update that kind of thing, update and tell the team, somebody might come in to try to do an x-ray on them or do O2 or yeah, no, and that's the concern.
Yeah,
it's like you don't know, and so communication is super important with the care team. Anybody else? That was a great experience. Thank you for sharing.
I had my first terminal extubation.
Okay, how did that go?
It was good. It
Okay,
was sad, but it was good.
want to give us a brief rundown or breakdown?
So she had come in for anaphylactic shock.
Okay.
She was only 58. Her family decided that they didn't want to keep going with it.
Okay,
Nobody was there when we withdrew care, so it was really sad. She was by herself.
sure.
Her kidneys were failing. They wanted to do donation, but couldn't. So it wasn't bad.
Okay,
It was pretty good.
okay. Did they let you extubate?
They did.
How did it go?
Good.
It's
I
not
cried
easier,
while-
right?
I cried while extubating, but it was good.
Okay. Has everybody had a chance to extubate?
I
Is there
have.
anybody who hasn't done an extubation yet? Okay, so as somebody who has done, as a therapist who has done an extubation, what tips or information would you like to share with your classmates who haven't done it just yet?
Yeah, we did an extubation on a live patient too. So
Okay.
suction, because it's nasty when it comes out.
Okay. Good.
I don't know. It's pretty simple. There's not much to it.
Okay.
Deflate the cuff.
Yeah, definitely want to
And
deflate
then
the cuff.
you suction as you pull the tube out.
Okay,
That's a
so
little complicated to do all at the same time.
yeah, no, but that's the thing. That for those who haven't had a chance to do it yet, everybody has their own way of doing things, and as long as you figure out your own system, what works best for you, there's no, most of the time there's not really a right or wrong answer. So as far as extubation is concerned, from my perspective, I would just make sure you have all your materials ready, everything that you need. So you want to have a syringe to be able to deflate the cuff. You want to have suction ready. Depending on how long they've been tubed, you might want to do a pool mist. There's a lot of different things you could do, but one of the biggest things and easiest things I saw was just having blue chucks out.
Yeah.
Okay, so blue chucks on the patient's chest, because you're trying to make it as smooth as possible. So you put the chucks on their chest, you have all of your materials ready, so that it's one real quick, easy, swift motion of deflate, pull, goes right into the blue chucks, roll, and throw it away. Okay, whatever like I said, you'll follow RTs that have their own way of doing things, and just take bits and pieces of things that you do like, so that you can incorporate it into how you approach it. I don't know if I shared it with you guys. So I went in with one of my managers that told me, actually no, I did go with him. So sorry. So my family and I are from Hawaii, so Polynesian families are huge. And especially Tongan families, like they will, fill up an entire ICU room and stuff. So this one time they decided that they were going to withdraw care. So we were going to go in an extubator, and we had to literally shimmy through bodies as we were walking into this patient's room. And so my manager asked me, do you want to do it? His name was Rob. Rob was awesome. He's like, do you want to do it? I was like, no, I'll let you do it. So we walk in, and before we go get our stuff ready, a family member walks up to Rob, puts their hand on his shoulder and says, hey, are you going to be the one that takes her away from us? We heard Rob all looked at each other like, bro, this is crazy. I mean, you know, we try to be professional. We try to keep a straight face. We're just like, you know, we're just here to, you know, disconnect her. You know, we kind of redirected the question and the comment. We're just like, hey, we're just here to, you know, remove the breathing tube from her to make her a little bit more comfortable. So, you know, that's one way to approach it. But then we went in, extubated her. You know, she was, you know, breathing for a little bit. We, you know, cleaned up. You know, wiped her mouth, you know, even just having like a warm towel or cloth for the patient's mouth to clean up afterwards. The suctioning is definitely a huge benefit. But, you know, if it, in that essence, you know, if it's end of life kind of deal, you know, you just want to make the patient as presentable as possible. If if they have a bunch of family members around, when you extubate them, you are more than welcome to ask them to just step out for a bit to perform it. Because, you know, some people just might not be comfortable with having, you know, an entire family watch you kind of, you know, yank this tube out as they're like gagging and coughing on it. You know, it's uncomfortable. So, you know, when you're going to do it, at least for the first couple of times until you get comfortable with it, be like, hey, right now we're going to remove the tube. You know, we're just going to ask the family to step out for a moment, and that's totally fine. Okay?
Our patient also bit down on the end of the tube as we were trying to pull it out.
Yeah, that happens
fun.
too.
Didn't know how to get it out.
Because unfortunately too, they're, you know, a lot of times they're not in their right mental state. Whereas other patients, you know, they're like 100% with it. You know, they go walking with the vent. They walk and for the most part walk and talk as much as they can with having this big old tube in their mouth. But they're with it. But in that sense, you know, there are instances where the patient's like super groggy, out of it, and you have to talk to them. You have to talk to them and let them know. Okay, that's part of your bedside care is, hey, I'm Dallas, I'm the respiratory therapist, we're going to remove this breathing tube, okay? And then so you just kind of talk them through it. It's like, hey, we're going to deflate the cuff, we're going to have you cough, okay? And that's another thing that you can do too. It's like as you're pulling it out, you're going to instruct the patient, cough, 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 cough. And as they're coughing, that will make it a whole lot smoother as well for you to remove the tube as well. And like I said, you're going to listen for breath sounds. You're going to check their airways. You're going to hope that they have the least, when you removed it, you caused the least amount of extra irritation and damage to the throat. Because unfortunately, there are times where when whoever put the tube in, they might not have been gentle. It might have been a rough or difficult intubation. And so whatever you can do, because now, you know, nobody knows who the provider was that tubed them, you know, whether or not it was an easy or difficult one, but now you're the last person to, you know, have any kind of association or affiliation with this breathing tube that's in their throat. So, very good. Any questions for our extubation? Okay, like I said, you guys will figure out what works best for you. But like I said, something as simple as just asking the family to step out whenever you have to do something, even if it's just suctioning or a breathing treatment, you know, and do whatever allows you to do your job. And if it's something as simple as like, hey, we're going to give them a breathing treatment, which sometimes can cause them to cough. If they're vented, it can cause them to, you know, set off the alarms. You want to silence your alarms. You want to crank your FiO2 up, okay, when you're doing it. Because like I said, these are all things that will happen when you're doing your job and your patient care. And so something as simple as just asking family to step out for a bit, you know, we'll let you know when they're ready to go. You're always welcome to ask the nurse and the techs for help as well. If you're missing supplies or you're needing stuff, it's always easier to take your time to find all the stuff that you need before you get started. Because once you get started, you commit, then you're kind of stuck unless you have extra hands to help. Cool? Sweet. Anybody else? Rookie mistake, extubation, these are good stuff. These are good things, like I said, when you guys get together, for you guys to be able to communicate and powwow, because that's how you guys are going to grow and learn that much more faster and quicker, so that by the time you guys hit the ground, you guys are off and running already. Okay? Questions? Concerns?
I have a question. I just remembered in my clinical, we withdrew on a Polynesian family as well. I don't remember where they were from, but as soon as the patient like passed away, they started like wailing. Yeah, that was intense.
So
it was very different.
So there's going to be, you know, you're going to get patients from different cultures, and you know, we try to be as respectful as we can be. Like I said, do what you got to do, and then just expect just different things to happen, things that might be out of your norm, which is totally fine. But yeah, there are some cultures other than Polynesian that I'm just like, hey, everybody mourns and does things their own way. Like I said, you just try to be respectful. Once you're done with your thing, you step out, you chart it. You can chart outside, just make sure you get all the numbers that you need when you step out. Because like I said, you're trying to get in, do your thing, and get out to try to make it as smooth as possible. But at the same time too, it's like, now that you have all your information, you can just find a nurse's station, do some charting out there. That way you're not in the room, especially too now with ICUs being filled up with, COVID patients. You want to try to spend as little time as possible when you have to be in there. Sweet. Any other stories, experiences, clinical stuff, questions? Perfect. Do me a favor, take one more 5-minute break and then we'll come back, okay?
Can I watch this?
I had one patient that they were trying to shock him back into a rhythm while he was awake. And they wouldn't stop either. We're like sitting there, and all of a sudden they're like, clear, and like, what? And he's like, oh! I'm all like, what are they doing? That's bad management, but that's the kind of weird stuff you can see. Like, they hit him at least 3 times, and he's just like, oh! Sure. So, it's just an antibiotic. It's really commonly prescribed. Unfortunately, it's like a lot of different things. It has quite a bit of list of different types of things. It's kind of like the go-to if I have a patient has a flu, I would get they would get prescribed that.
But if it's a viral, then there's no need technically.
Technically, yeah.
Okay.
They a lot of
I'm gonna cause harm, but it's not gonna be helpful.
Yeah, it won't be helpful. Usually the biggest concern for like bad dosing with antibiotics is resistance. So we always hear about MRSA and Pseudomonas, which are all antibiotic resistant, but that's unfortunately because of poor dosing of antibiotics.
So basically only one time take prescription.
Yeah, on
it's
Monday,
okay,
and
it's
Wednesday,
constant.
and Friday.
Yeah. It can eventually cause problems down the line, but that's like oh, you came in, you have a sniffles, here you go, here's a Z-Pack. They just refer to it as a Z-Pack. But it's very common, but like I said, if it's a virus, that's not gonna help, because it's an antibacterial. There's not too many virus medications out there. But it's one of those like, the patient came in to be seen. It's not one of those like, nobody wants to hear the doctor say, oh, just go home, take some fluids, some chicken noodle soup and rest. It's like, oh, we'll give you a prescription for this antibiotic.
It's awful. PFT's not till 8.
What time's your
My clinic will have to be there at 5.
Where are you at?
Okay.
That sucks.
It's way better.
awful.
Like 7 to 7:30.
No, I like
to IMC.
but I used to drive to the Salt Lake Regional, and I didn't have to be there till 6:30. I didn't have to leave my house till 5:30. I have to be at the hospital at 5 now.
You're never fine.
But
But
get out even
7 to
earlier.
7:30
I go to bed at 8
Yeah, I'm not gonna lie,
o'clock
it's not my
anyway, so, like,
favorite.
last night I went to
I
bed
wake
at
up in the
8:30.
dark,
I was so
there.
tired. I
I
was
see the
out. My
sunlight
husband
through
was
the
like,
windows.
so much for
We
seeing
get
me,
out,
and I was like,
and
you're
it's
so
hard.
tired. Eat your food.
Oh my gosh, at my
No, we worked
ABG
late
one,
yesterday because
when there's like a patient who coded at like 6 a.m. And I was like,
my
wow,
God.
what a
Like,
pretty sunrise.
7:30. I was ready for bed. I was like,
I'm like,
I don't got time. I'm going to sleep. He's like, I'm gonna go get dinner. And
What
I was
do
like, okay, I
I-
might be asleep when you come back upstairs. I was.
it's
I was tired.
tired.
We were also really busy. The ICU was completely full.
No, it's
so it's really fun. We were down to one vent, and we started to panic. We were like, what are we gonna do?
Well,
But we estimated like 4 people, so
Oh, good.
then they had 4 more vents for 4 more people.
I hope
Job
I don't
security.
die.
Okay?
Yeah.
It's all how y'all look
I
at
don't
it.
know if it's, they're shorts. Like there's like 2 or 3 that called in.
Oh, really?
So
Yeah, so that's why we were busy. 'Cause
their
everybody had, like,
IMC is now
overload work.
overflow for ICU.
Oh,
So
I
my
hate
first
when
week,
my
that's where I
preceptor
was.
makes me chart.
But it's
Do they make you chart?
Yeah.
ICU
I hate it.
basically.
Because
And
I was
yesterday I was in the actual
I
ICU.
always, and they like stand there and watch me, and they like, whoever I was with, Josh didn't make me chart, but the one before made me, and he would be like, you need to go back. I'm like, did you freaking charge?
Busy.
It's not my job.
Like the whole day. I'm like, I'm not here to charge.
Oh,
I'm
you
doing-
charted everything?
I charted everything.
They were like,
Yes.
coming back up.
That's why I'm so angry.
I was like,
It's yeah. I've had 2 preceptors at both locations that made me charge. Yes.
Like, look at
And he'll
the
be like-
house in here.
alcoholic.
Well, he'll stand behind me, and I'll be like, well, can you like look over it so I don't miss anything? Because this is not my charting. This is you. And so, like, they'll look through it, but I'm like, this isn't my job. I'm not here to chart. That's not on my purple sheet. It's on my purple sheet.
I still have the smell stain.
Oh.
I've charted too.
Really?
At
And necrotizing.
Because
Fasciitis.
they don't want to.
Yeah, I feel like if I mess it up, I'm like, that's not you. That's your.
I think if they ask me to chart, I'm just like, I don't feel comfortable charting under your name. Because if I mess it up,
Like it's
it's not on me.
Yeah, it's just like a rock. I was like,
Oh, it makes me so mad. I
I
hate
think
it.
that's a good thing.
All day. All freaking day.
I get a couple
Head off.
but it's like
Inmate on.
There you go. That's all
Well,
you
he would do the breathing treatments and listen. And like,
you were like, I'm supposed to be doing
Was he awake?
that.
No, he wasn't awake.
Oh, okay.
And there
who
was
was just doing it here?
How was it?
Yeah.
Russell.
Russell made you chart.
And Becky made me chart it. Davis.
And sedated.
Becky was a bitch too.
Oh, yeah.
No. Davis. I hope nobody has to face.
Really? I went to work on my computer and my tablet.
Yeah, someone's like, oh, who's that? And she's like,
75.
she's a no one.
Something else, and the doctor's like, all right, just turn it off.
I was like, hi, I'm Bailey.
And we were like,
Hi,
okay. It was already an aggressive
And in
patient.
one
He
of
wanted to stand a
my
lot.
like comments, she put,
Took all
she
the
needs to
sedation
walk
away,
faster.
And his sats just tanked.
Oh my
He was
god.
wailing all around.
Isn't that
They
funny?
ended up putting more sedation.
I was
You
like,
guys should write a book. I think if you guys compile all your different experiences.
Yeah,
Becky,
we
don't
have a
make me
crazy
hurt.
book.
Don't walk faster, okay? Okay?
Because everybody has stories like that.
No, I feel bad.
You shut up. I would have.
Maybe not the best idea.
What's your deal, man?
No, I feel bad.
A 2.
You should have a class
Give her a
journal.
2 for not walking slower.
All right, let's get started.
She left
Any
me behind.
questions
Every
about
single time.
last week's material? There's a couple more quizzes I gotta go through.
No, Russell. I wonder who's with Russell.
I'm trying to be a little bit better and judicious with some of these questions. I will admit some of the questions
That's
are
cool, I guess.
poorly worded. And so I assure you, if I take a look at it and the question sucks, I'll toss it, or for sure, definitely give you guys some points for it. I got a little bit better. I got a little bit better with my schedule with between football and my work situation and class. So everything is slowly syncing up. So if you ever have questions or need help, shoot me a text, email me, I'd be more than happy to help you. I overheard their story about a prisoner or
Never mind.
a friend with handcuffed with jewelry. But we had one before I get started because it was a hilarious story. So this one guy came in, he was handcuffed to his bed, and for some odd reason he ended up in the respiratory ICU at IMC. And I thought it was weird because he was totally conscious and with it. But apparently the police had pulled over this car that was kind of swerving, and the 2 guys had overdosed, and like the guy literally still had a needle in his hand and the car in his arm, and the car was still like moving. So the cops pull him over, they're about to take him to jail, and one of the guys throws up and there's like rubber balloon pieces in his throat. So now they know that the guy is a drug mule. So they took him to IMC, they gave him Go Lightly to try to make him poop it out. So the whole time they're just they're just pumping him full of Go Lightly, nothing. And the nursing staff, they're all like, just dying, just like, really? So finally, I guess at the moment of truth, when the guy had to go, the nurse was like quickly trying to like slide the bedpan underneath him, she wasn't able to get it all the way underneath him. She was kind of like in it at the side, and just it like exploded and found its way like with the curvature of the bedpan like up. And so it was just kind of like everywhere. It was super gross. And the funny thing was there were 2 cops there at the time, and one of the cops just started laughing. And so one of the nurses asked, why are you laughing? He's like, oh, I'm senior officer. So that means he has to, and the poop is all considered evidence. So the junior officer was the one who was responsible for collecting and sifting through all of that mess for, going after this guy. So, yeah. So, yeah, just know that you guys are in for some winter stories, okay?
Maybe not that one.
With that being said, we will now dive into the wonderful world of mucokinetics and surfactants. Has anybody, you guys haven't done rotations with the babies yet, have you? Or no?
No.
Okay. Surfactants, normally you won't deal with surfactants until you guys have rotations either up at primaries or in any rotations in the NICU. So this test or chapter doesn't talk about it a whole lot, just pretty vaguely. But like I said, whenever we go over stuff, I will try to emphasize things. One that you guys should know for your, as an RT, and then whatever might be pertinent to your quizzes or tests coming up. Okay. Let's see. So the objectives, we're going to define some key terms related to mucokinetics. Nobody even calls it a mucokinetic. We'll talk a little bit about some A&P, about production, function, and clearance of mucus in the healthy lung. There's a running joke that you can tell if you're in a room of nurses or respiratory therapists. Respiratory therapists if you ask anybody in the healthcare whether or not they would rather wipe butt or suction, that's how you tell if you're an RT or a nurse. Because in all honesty, nurses would rather clean up bowel movements and urine than suction a patient. And me personally, I would rather shimmy a tube down, an enclosed tube down somebody's throat to suction than clean up. So we'll state some of the indications for a bland aerosol. Nobody calls it a bland aerosol. And some mucolytic agents. We're going to compare and contrast mechanisms of action. Do you guys understand? So mechanisms of action is a pharmacy term. Are you guys, do you understand the concept or what that means, the mechanism of action is? All it is just a fancy way to say, how does it work? So like when Rylan was talking about the atorvastatin, it works by reducing cholesterol. That's in essence its mechanism of action. It works different ways. So like how many bazillion commercials for blood pressure medications do you see or hear on the radio? Same thing with like rheumatoid arthritis and eczema. There's lots of different medications for the same indication or purpose, but they all work a little bit differently, and that would be their mechanism of action. We'll talk a little bit about surface tension and oxygenation, work breathing. We'll talk a little bit about surfactants and some of the exogenous or manufactured surfactants that you might see in clinical or at work. So a little A&P. So we're looking at, when we talk about mucolytics, we're looking at the lungs, we're looking at different cells. We're looking at the mucosa, submucosa, adventitia, basic A&P. You guys have had A&P or have been doing A&P? Yes? Mm-hmm. To some extent? Okay, perfect. I don't want to repeat stuff you guys are familiar with. Quick picture of the different layers. For future reference, do you need to know the different layers? No. But there are some different aspects of it. So like the cilia, your mucus, that will be important for you guys to know regarding RT stuff. But good picture kind of breaks it up into like the different areas where they're found. Let's see. So have you guys heard of the mucociliary escalator before? Okay, who can give me a rough definition? Imagine I'm your patient and you're trying to explain to me the mucociliary escalator as far as how it helps me as a patient who's in for pneumonia.
Well, it's just like the name.
Okay.
You just envision an escalator
Okay.
with all the little gunk hopping on and it going up and out.
Perfect. The book kind of gives it a little bit more explanation as far as even like the rate at which the cilia is moving crap along the mucociliary escalator. So in essence, we know that it protects our lungs. It also provides warmth and it humidifies the gases. Oddly enough, aside from the mucociliary escalator, our noses are also responsible for warming and humidifying gases. Surprisingly, in the brief amount of time it takes you to you or a patient to inhale through your nose, that in that instance your nose has warmed that air, humidified it dramatically from the time you actually just took a breath. So pretty crazy. So everything that's, you know, the respiratory tract is fair game for you to know as much as you can about it. Mucociliary escalator also prevents heat loss. There's a couple layers. There's a gel layer, which is sticky, and a sole layer, which is a little bit more of watery consistency. So the mucus molecule is 95% water. Always important to maintain proper hydration. Fortunately, in the hospital setting, most patients, if there's a concern for hydration, they'll just get them an IV bag. Let's see, the remaining 5% of the mucus molecule is made up of proteins and lipid molecules. You won't need to know like what they're made of, but you'll know, just mentally keep a note that a lot of the medications that are used to thin out, break up, or loosen mucus, this is where you'll see their mechanism of action. They'll break up lipids and proteins to thin mucus out. If you know, there are a lot of different conditions that can increase the thickness or the production of mucus, but when we provide a medication, this is where that mechanism of action will take place, where it's breaking these disulfide bonds and hydrogen bonds to be able to help the patient out. So this is a very in-depth picture of, it says mucus, but you don't need to know that. Don't worry about that one. The function of mucus, I like these little boxes of info. They're actually pretty helpful. So your mucus will prevent water from moving into and out of the epithelium. So the mucus just kind of provides a physical barrier to prevent it from, I guess, leaking into areas where it normally isn't. But unfortunately, when patients are sick or in a certain condition, you know, all kinds of different things are going to happen. But the mucus, a lot of people don't like mucus, but it serves a big function for protection and for health. So the mucus is shielding the epithelia from direct contact with toxic materials, irritants, and microorganisms. Mucus helps prevent infection by, so your mucus actually has enzymes in it that helps to break down microbes that come in. It also provides lubrication for your lungs. Questions, concerns? Bueller, okay. Structure and composition of mucus. So a properly functioning mucociliary system equals healthy pulmonary system. A lot of times if they have a healthy pulmonary system, they will not be seeing you in the hospital. When we consider when a patient gets sick, you know, their disease state is now going to, as far as how it affects their mucus, it's going to affect their volume. In some cases, it'll crank it up. In other cases, it'll actually dry them The consistency, it could either be super watery and runny, or it could be super thick. And then it can also determine the structure of the mucus. It'll shift a bit depending on what's actually the cause of making them sick. Let's see, the respiratory tract irritants causes, so if, when we have bad air quality, whether it's the wildfires or just the inversion, any kind of irritation to our respiratory tract or to the mucociliary system, that in itself will cause an increase in mucus production. There are some disease states that are associated with lots of mucus, cystic fibrosis definitely being one of them, pneumonia, and chronic bronchitis. Who can tell me the difference between a bacterial infection and a viral infection, and what color it produces with the mucus or phlegm?
Bacteria is
Green.
green.
Okay. And viral would be what color? Yellow. Okay. Surprisingly, when you're in a room of RTs, anytime a patient coughs, sneezes, or produces phlegm, the RT will want to look at it because that can tell you a lot. So if it's green, that's usually indicative of some type of bacterial infection. It's crazy, but it's true. If it's yellow, most likely it's viral. But what are we looking for a healthy patient? It's clear, it's thin, it's very visible. So as RTs, just what a patient spits up can tell you as an RT the health of your patient, the condition of your patient, and that can also guide you as far as what would be appropriate treatment plans. Like you might talk to the pharmacist or the provider and let them know, hey, we suctioned them, they had a bunch of green phlegm, I think it might be some type of bacterial infection, and they would then appropriately prescribe the right types of antibiotics for the patient. Okay, so mucus, phlegm, it's your cup of tea, your forte. Cystic fibrosis patients, like I mentioned earlier, a lot of CF patients, at least when I worked with them, would save their phlegm and spit and sputum. But like I said, they were experts in it, and they could tell you, based on their history, whether or not they were healthy. They could tell you a lot from their phlegm. It's kind of gross, but that's part of the gig. Questions, concerns about phlegm, sputum? Let's see. So these are conditions that would increase either the volume or the thickness or viscosity. Viscosity is just another fancy way to say thickness. Bronchitis, asthma, cystic fibrosis, pneumonia, acute bronchitis. Okay, what class of patients have a lot of these in their class? Sorry, I don't know if I worded that well. So obstructive or your COPD patients. Okay. Anytime you get a patient history and it says COPD, you can expect a lot of times, they're going to have a lot of volume of phlegm or mucus. It's going to be thick, most likely. And then on top of COPD, some of these additional bronchitis or pneumonia also being in alignment with that. So as far as disease states, we've already kind of discussed, those can affect the ciliary function. So the cilia are slowed down by thick mucus, dry gas, smoking. Did you guys know that smoking affects your patient's cilia? Okay.
Burn them off?
The what?
Don't they get burned off or something?
I don't know if it necessarily gets burned off, but it affects, if our patients are smoking and that smoke is sitting and marinating into the phlegm and into the mucus, in essence, it prevents them from functioning at their peak performance. So in the book, I saw that it actually determines a specific rate at which it moves and pushes crap up the mucociliary escalator. Now imagine if they're smoking and they're sick on top of that. So imagine a smoker, pneumonia, history of COPD, and then COVID on top of that. Okay, their cilia is is like almost stagnant. It ain't doing squat. And so that's the kind of patients you'll probably see here coming up in the fall and winter time. Okay, one of the biggest things that we can do is reinforce to our patients immunizations. Get your flu shot, get your COVID shot if you haven't gotten it already. You know, if your patients are 65 or older, that makes them eligible for getting their pneumonia shots. Okay, these are things that you guys as RTs can recommend to them to help their conditions and help their health. Because the better you educate them, and they'll be more compliant, and then you won't see those same patients as often in the hospital. Okay. So cilia are slowed down by noxious gases, PPV, endotracheal tubes, high FiO2, and atropine administration. So the atropine, we've talked a little bit about that in a previous lesson, I think it was last week. So, you know, these are all different things that can affect our cilia. We want our patient cilias just firing off like catapults, just moving stuff along. But there's always going to be conditions that will affect that. So
what is atropine?
Physiologically, I think it just slows it down because we're stimulating either the parasympathetic or the other one, yeah. So we're preventing it. It just slows it down and stops it from moving, from a, I guess, chemical standpoint.
Wait, with atropine, it was used as like a bronchodilator, but we don't use it that much anymore, right?
You'll see it, but not too often. There's a lot of medications that, you know, as new medications come on board, they'll replace old ones. Some doctors and some facilities have their set go-tos in place. So you guys just have to be flexible with what your facility uses or what your providers are using. And that can change from rotation to rotation, or place to place. So either one of these can impair the cilia. So ET tube, extreme temperatures. Have you guys set up ventilators yet? Yeah?
Yeah.
Okay. So we put a humidifier on that thing. Please make sure for the love you guys change the water bags for your humidifiers. Okay. You know how many times you walk in and the patient's getting dry air because you look at it the humidifier is alarming because it's overheating because there's no water in it. Okay. So anytime you guys go into a room and you hear that, please just change the water bag. High concentrations of O2, dust, fumes, and smoke, dehydration, thick mucus, and infection. All these things can impair that. Let's see. So structure and composition of mucus. So increased mucus production and impaired ciliary function can overwhelm the pulmonary system. And so now we're looking at it from a pharmacologic standpoint. So a lot of times these are just some, I guess, first line options that you could throw out there. Keep in mind, anytime you do any one of these, you push for or advocate for one of these options, please know that you will need to get a doctor's order for it, especially for any kind of medication, and make sure you are charting. I know charting is a pain in the butt, but if you didn't document it, it did not happen. And when crap hits the ceiling fan, documentation is going to be the only thing that saves your butts. So as far as treatment for mucus, we're looking at water. So water, when I say water, I mean like just hydration, fluids, something as simple as, hey, you know, how much water have you drank today? You know, if they have an IV bag, you know, you could figure out how many IV bags they've gone through in a short period of time. Saline solutions and expectorants. Let's see, we also will do some mucolytics. This will affect the consistency of the mucus. And then we could even throw out some bronchodilators and corticosteroids. Anytime you see a steroid, keep in mind the steroid is intended to reduce swelling, reduce inflammation, and kind of put everything, calm things down. So anytime a patient comes in, they are in an inflamed state, like to some extent. Everything's out of whack, and a lot of times a steroid, whether it's injection, whether it's oral, will be like the biggest thing to help at first. Questions? Factors that can lead to dehydration and thick mucus, increased respiratory rate, increased depth of breathing, fluid loss, and infection. I don't know if deep breathing would necessarily lead to dehydration, but you know, definitely the fluid loss or infection will affect that. Bland aerosols. So the bland aerosol, we're going to alter mucus water content. So some examples that the book uses for bland aerosols: water, normal saline. If I highlight it in red, it's important. Keep that in mind. So normal saline is 0.9%. It could be written like that. It could be written as NS. It could be written as NaCl. Get familiar with whatever abbreviations or shorthand your facilities use, or even how you document it, okay? Hypertonic and hypotonic. Has anybody had to give a hypertonic neb yet? Yeah? How did that go with your patient?
They don't like it.
Okay, they don't like it, all right? But if they have super thick mucus, if they're not coughing it, because imagine if their mucociliary escalator isn't working properly. Imagine their secretions are increased and they're super thick. Okay, they are fighting gravity, because if they don't cough it up, if they don't spit it out, if they don't swallow it, it's all pooling, imagine physically in their lungs, which will eventually lead to pneumonia, which will eventually lead to the ICU, which could eventually lead to a tube. Okay, so however you need to break it down or explain it to your patient, you need to reinforce to them that we're trying to prevent more extreme measures and bigger hospital bills, because it's crazy. Questions, concerns? Some more delivery methods. Humidifiers. Anybody has everybody had a chance to set up a bubble bottle? Is there anybody who doesn't know what a bubble bottle is? Raise your hand. Okay. Different facilities will have different ones. We're also, let's see, so bubble bottle, that's super easy. Sometimes your patient's noses will dry out, so tell them, some patients will ask if they can have some Vaseline. Unfortunately, Vaseline does not work well with nasal cannulas, and it can kind of melt it or deactivate it or just kind of warp it. And so if their noses are drying out, I don't know if IMC still has it, but IHC uses emu oil. Comes in a little white packet. Okay, if you get a chance, ask your preceptors, like, hey, we're trying to figure out what, if a patient complains about a dry nose with their bubble bottle too, what do you guys use? And like I said, they might bust out the old emu oil. Let's see. So yeah, so humidifiers, and then there's nebulizers. I don't know if it counts. You can do it. Nobody really does a small SVN, but they have like the larger setup, large volume. Has everybody had a chance to set up one of those? Yeah. Okay. Make sure your heater works. Make sure you check your bottle. As you guys become more seasoned RTs, you'll be walking past a room and you'll be able to hear whether or not that large bottle is empty or dried out. It makes a different sound, and you guys will actually get used to it. So if you have on your run your patients have nasal cannula or a large bottle, check it often. If you need to replace something, if the heater's not working appropriately, make sure it's not, your tubing isn't allowing water to pool on the ground. Because when you're working with the water in your tubing, a lot of times it's going to leak and it's going to get all over the floor, and it's a safety hazard. So just little stuff to be aware of. Direct installation still performed, but it's not used very often. I don't think I've ever seen that done before. So just an example for a simple humidifier. This is super old school. I've never seen one of these, but there are a lot of different options. Check with your facility, check with your preceptors. Hey, we talked about humidifiers. What do you guys use? What do you like? What do you prefer? Everybody's familiar with like checking the FiO2 with the little meter thingy, yes? You put it in line, crank up the O2, you bleed in the O2. If you're not, check with your preceptor. Small nebulizer, once again, it doesn't look like that, but that's kind of the concept. Like I said, you'll actually get used to certain sounds, so you know when your nebulizer for your patient is complete or not. You can't flick it to try to, get it down there. You're trying to get as much out of it as you can with the patient. Let's see. Let's take a quick 5-minute break, and then we got we're about halfway-ish through with the slides. So a neb with a hypertonic solution to get them going. Because you're providing and irritating their respiratory tract, you may need to pre-treat or post-treat with a bronchodilator. It just depends. So a lot of times you might have to do a hypertonic with a COPD patient, a lot of times with a cystic fibrosis patient. How many of you have had a chance to work with a CF patient before? Okay, so this, you'll see a long list of meds and treatments that you have to do, and you could spend up to 30 or 40 minutes with one patient, with a CF patient. So normally, if the supervisor has enough staffing for it, they'll accommodate for the time that you will be in room with the patient, so that you're not having to check on 2 floors of patients. But it's something to be aware of. Then I don't see this too often, a hypotonic solution. So this would be less than 0.9%. It can be used as a diluent. Less irritating than sterile water or hypertonic. This would be more like just plain old water. You'll need to use or be familiar with whatever your facility uses. Just be familiar with that. So just remember hypertonic, hypotonic, isotonic. Questions? Okay, moving on to mucolytics. So if a patient has thickened secretions, they're going to have, the thickened secretions will have waste products from the inflammation, so a bunch of crap. I'm not quite sure why it says DNA and cellular debris, other than cells breaking down and being stuck in the mucus. But then we'll provide a patient with mucolytics just to break down the mucus. So who had the presentation on acetylcysteine? Okay, so a mucolytic that we'll use is the N-acetylcysteine or the Dornase alpha. Has anybody had to administer either one of those medications yet? Okay, just be aware that is in your handbag of tools. So acetylcysteine, it disrupts the disulfide bonds in the mucus. So like I said earlier, you guys won't have to know the minuteness, but that's its mechanism of action. A very unique characteristic of N-acetylcysteine is it does smell like rotten eggs. Like we had learned earlier before, N-acetylcysteine can be administered in acetaminophen or Tylenol overdose. Acetylcysteine will cause bronchospasming. So if any time a treatment or a situation can cause bronchospasming, then you'll want to have a PRN, an order for a PRN treatment available at any time. Acetylcysteine comes in a 10% to 20% solution. It's inhaled. It can be used as a neb. You can do a direct instillation, or they can ingest it, but that's not usually how it's administered. And like I said at the end, before, you can either give with a bronchodilator or after, or before or after. Sometimes RTs will mix them up. If you're stretched for time, you could do that. But like I said, you want to, you're trying to do, prioritize your needs. If you have your time management's always going to be important. So if you have, 5 other treatments you got to go give in the same hour, then you want to coordinate it accordingly. This is what the mechanism of action looks like as far as where the acetylcysteine is helping out, or the mucomist. The other medication or mucolytics would be the Dornase alpha or the pulmozyme. So this is a proteolytic enzyme that breaks down DNA. So there is an aspect of the mucus that has some DNA in it. So this is where the pulmozyme will work. It's given once a day. It'll be refrigerated. It'll be usually in a light resistant container. A lot of times if you open up the refrigerator in the med room, you'll see like a dark brown bag, which looks a whole lot different than the other bags that you're used to. Most likely it could be a pulmozyme for that patient, or it could be some other light sensitive medication. Dornase alpha or pulmozyme is a treatment for cystic fibrosis very commonly. Because it's light and temperature sensitive, if it's kept out at room temperature over a day, then it's no longer effective or useful, so you'll go ahead and chuck it. A unique tidbit for Dornase alpha or pulmozyme, that there are device-specific setups for its use, technically. So a Perineb, a Hudson T updraft, or a Marquest, those would be approved nebulizers for using pulmozyme or Dornase alpha with it. Pulmozyme is good for breaking down the mucus, but it can cause irritation, chest pain. It can cause conjunctivitis, eye irritation, so stuff to keep in mind. But yeah, Perineb, pulmozyme, Dornase alpha, good stuff. So that was our mucolytics. We also have expectorants. So an expectorant will thin out the mucus thickness or viscosity, and it can stimulate cough. A lot of times a patient might get this most likely from, and there are a lot of over-the-counter options. Guaifenesin or Robitussin is a very common one. So a lot of times a patient might ask you, hey, I have a thick, productive, mucusy cough. What would be a good option for them? Guaifenesin or Robitussin will be a good option. Okay, this will actually help to thin out and break that down. I'll also usually recommend to them they increase their fluid intake while they're experiencing this with either a cough, cold, or flu. Another typical expectorant, like we had discussed earlier, like with the CF patient, would be the hypertonic saline. The stuff that's highlighted in blue, it lists it, but you'll never really see either one of those options in clinic or in real life a whole lot. So a terpene hydrate and ammonium chloride or potassium iodide, I've never seen or just used that before. So some more information. So acetylcysteine, the Dornase alpha, the guaifenesin. Let's see. So pulmozyme, Robitussin, this is that mucomist. You may or may not use it depending on what your facility is used to. Antitussives or cough suppressants. So surprisingly, if a patient's coughing, that's a good thing. Okay, a lot of times if somebody's coughing, as long as it's a productive cough and it's moving stuff out, then coughing is a good thing. But in this case, a patient would need a cough suppressant if it's a dry or hacky cough. If something's highlighted in orange, that's more of a, hey, this is a Dallas pharmacist thing. So if you or patient is experiencing a dry hacky cough, just some Delsum or dextromethorphan is the go-to. That's the DM. If you ever wondered what Robitussin DM is, all it is a combination of guaifenesin, which will thicken out or thin out the mucus, but then the Delsum will actually help as a cough suppressant. Like I said, if your patient is complaining of a dry hacky cough, it's not productive, then Delsum would be your go-to. If they have a thick, mucusy, you can hear it when they cough, you can hear like the phlegm and the mucus in there, then a guaifenesin would be a better option. Codeine, that's usually another cough suppressant. A lot of times it's not used or prescribed all that often because it's abused. So promethazine and codeine, guaifenesin and codeine, those are only available with a prescription. But like I said, it's a controlled substance. It's helpful. It's been used before, but unfortunately that eventually leads to a lot of abuse. Questions? So this wasn't in your book or the lesson. I just added it because I know you'll see it with regards to mucus and phlegm and all that crap. So pediatrics. So when kids have a lot of mucus or phlegm, the biggest concern would be dehydration. So with helping with mucus, fluids, hydration, you can recommend some Pedialyte. That has the electrolytes without with a lot of the sugar that Gatorade or Powerade might have. It comes as a liquid that you can, throw in the refrigerator. It also it's available as a popsicle too. So like your croupy kids, it could be helpful for them.
Sick people love popsicles.
All right, so people love popsicles, ice chips. But make sure if a patient asks you for something, you check with the nurse's station first to make sure they're not NPO. Because if they're NPO because they got a procedure coming up, or they're an aspiration risk, then you don't want to give them anything like that. Let's see. So when it comes to kids, especially little kids, there's not a whole lot of medication that can be given, and so a lot of times doctors will write for a prescription for bronchiolitis clinic. Has anybody had a chance to help out or hear about a bronchiolitis clinic before? Okay, so it's actually a standing order for about a week, where the patient, mom or dad or family, can bring in their baby to get suctioned out by the RT as often as they need to within that 7-day time period, okay? Because when babies are super young, you don't want to give them medication. There's not very good dosing protocols for babies, and so the best thing when they're stuffed up, when they got a ton of mucus or phlegm, is suctioning. If patients need medication, especially for peds, for babies, always want to recommend to parents to follow the directions and the dosing on the label. For little kids, medications are dosed by age and by weight. If for some odd reason there's a particular patient or child isn't in the right age or weight base, then you would just defer them to talk to their pediatrician. Consult their pediatrician or their primary care provider. Most of the time, the only things that are really safe for little kids will be Tylenol and ibuprofen. It comes in a liquid, but that's by far the only thing medicine-wise that you can give that would be helpful and safe. Questions? If let's say I am a mother, I brought in my baby for the bronchiolitis clinic, how would you guys assess whether or not my baby is dehydrated or not? What's an easy way you guys can think of?
Wet diapers.
Wet diapers, very good, okay. So you would ask mom, how many wet diapers do they normally have versus how many wet diapers they have now in their sick condition. That's a very easy way to kind of gauge physically, and you can visualize, hey, they usually have 5 wet diapers a day and now they're down to 2, so you would just express, hey, we're a little bit concerned about their hydration level. Okay, good one. Questions, concerns? Okay, these are some simple suctioning, so everybody will get used to the bulb suctioning. Anytime I'd have kids come in for bronchiolitis clinic, I'd ask the parents if they have something at home for suctioning. If they don't, I just go grab them from the supply room, a bulb suction. It's up to them how they want to approach it, but like I said, I tried to go above and beyond and be like, hey, here's a way to do it, okay? So bulb suctioning, Walmart sells, Walmart, CVS, Walgreens, you can get one of these like battery powered one. So I bought one of these for my kids. Dude, these things are awesome, okay? If you push this yellow button, it starts it, but there's like another button that you can push. It actually turns on, it plays like nursery rhymes while you're suctioning. Okay, it's pretty awesome. This is a little container, it twists off. When you're suctioning, if you're not getting crap out, an easy tip is to close the other nostril. Close one nostril while you suction the other. Okay, that will provide you your you're suctioning enough of a vacuum and space to be able to effectively suction crap out. There's also this Frida system. This is like literally,
You suck it with your mouth.
you suck it with your mouth. So if you guys are not, these are just, like I said, these are options for you to express to parents, okay? I'm not expecting you guys to get a Frida system and go suction other people's babies. But
I'm actually gonna suction that baby.
like when you know, when they ask you, hey, what can I do at home? Because, you know, it might be a far drive or it might be super inconvenient for them to come into the bronchiolitis clinic as often as the baby might need it. You can send them home with a bulb suction, but let them know they can purchase either one of these other options at the store.
Are they very much
On
different price-wise?
Yeah.
Okay. That was assuming the main one is the most expensive?
It wasn't too bad. It was like 15 bucks. Yeah, they're nothing crazy. Like the Frida and the bulb suction, they're like $5. They're pretty cheap. It's literally like a straw with a hose on it. But I've actually had a lot of parents with the Frida system. Like that was like killer. Like it got it all out. Okay.
When my son was little, the doctor prescribed like a suction machine to take home with me.
You can do that too. As long as your insurance covers it, you know, you're trying to find what's most cost effective for you as a patient, you know, and your child, but then you're also looking out for your patients as well. Okay, and not everybody would have the ability to buy, you know, maybe the you know, this battery, you know, nursery rhyme singing pneumatic one that I bought because I'm bougie. So bulbs and you know, bulb suctioning, it's okay. It's not the greatest, but like I said, if there's anything that you can do to at least try to help the situation or better, then why not? Questions, concerns? There are other apparatuses and situations for suctioning, but these are just some common ones that you could share with your patients as well. Or, you know, yeah. Okay, questions, concerns about mucolytics, antitussives, expectorants. We're changing gears now and going into the wonderful world of surfactant. Not that you'll see it a whole lot, but you need to be aware of it and its place in therapy. Like I said, most of the time surfactant is something, and it comes in such small doses. Like I said, it's literally, the only ones who really are in need of it will be babies. So, like I said, if you're familiar with it, you know, when you go do your rotations in the NICU or at primaries, you know, you can, you know, ask your preceptor, hey, what do you guys use? You know, how do you guys base your dosing and stuff like that? There's I would say, like, if you go, when you guys do rotations in the NICU, you'll actually see the RT do a whole lot more than, say, with working with adults. Because you'll see the RTs will intubate babies more often because they do it so much that they're the go-tos for intubating babies. And I saw one occasion where my preceptor, she was, fortunately, everybody knew her, everybody loved her. And so this one resident was taking their sweet old time and having horrible results with tubing his baby. My preceptor literally pushed her out of the way and said, move out of the way, give me the freaking tube and I'll do it. You know, if you, in all honesty, you have to do what's best in your patient's interest. So if somebody's sucking at their job, call them out, push them out of the way, get in there, then that's what you need to do. Let's see, so as far as what we're discussing or what area of the body, so there's a section, there's an area, the lower lungs, or they call the respiratory zone. I looked this up in the book. It's an area of the lung where gas exchange takes place. So you're looking at gas exchange in the, with the pulmonary capillaries. So as far as size-wise and the breakdown, you go from, you know, your large airways to your bronchioles, which then becomes your alveolar ducts, and they are clustered like grapes. There's a picture right afterwards we'll take a look at. And then as you go smaller, you get the alveoli, and then from there, we're looking at exchange between the alveoli and the pulmonary capillaries. With regards to surfactant being produced, it talks a little bit about the alveoli consists of 3 types of pneumocytes. Type 1 are the larger ones. Okay, type 2 are important because the type 2 pneumocytes, that's where the surfactant is actually produced. So I added that the type 1s are large, thin, flat cells. whereas the type 2s are small. They're located within a type 1 pneumocyte, but this is where the surfactant is actually produced. Let's see. There's a type 3, but apparently it wasn't important enough to really talk about it. So quick breakdown. So as we go through the airways, this is the alveolar ducts, alveoli. These are the alveolar sacs. You guys have, some of you, I remember, had worked with the pig lungs before, yes? Okay, so it's a really easy reference, and there's lots of videos you can look up too. You know, from a lubricating standpoint, the surfactant, whether it's internally produced or externally administered, it just helps to keep the alveolar sacs opening and closing appropriately. Okay, certain conditions obviously will have an effect on that, and so we're trying to make sure that they're functioning at peak functionality. So when we talk about surfactant, that's what we're trying to do. We're trying to make sure that these alveolar sacs are open and that oxygen exchange is occurring. Surfactant helps to prevent collapse or overdistension. The book says that it takes more almost energy to reopen or pop open those alveolar sacs and ducts than it is to keep it open. A lot of times, like something as simple as coughing will help to pop open those things. So as RTs, we're big on cough. You know, they have machines that will almost suction out a patient to the point where it causes coughing. But we're trying to, you know, in essence, there are a lot of times where we're just trying to open up those alveolar sacs, get more O2 to try to bring up their oxygen saturation levels. The surfactant enables lungs to expand easily. Like I said, it's almost like a lubrication. An important factor of surfactant is it decreases surface tension, which allows the alveoli sacs to open and close appropriately. The surfactant will also help prevent the leakage of fluid from the capillary membranes. This is a rough picture. So type 2 cells are over here. This is the respiratory membrane. This is the surfactant. It's kind of like that lube, that lubricant that helps it to open and close appropriately. There was a listing of a bunch of different proteins. There aren't any questions on the test on it, so I deleted it. But this is just a listing of, hey, these are important proteins that you can find there. Does anybody care about them? No. Surface tension, an important Laplace's law. So this will always be true. The smaller the size or the sphere, the larger the surface tension. It's a very profound idea, but we're trying to increase the amount of the area so that we can reduce the surface tension. So surfactant decreases surface tension. It's produced in the type 2 pneumocytes, super important. It's stored in our body after its production. It does have a short half-life, so your surfactant comes literally in like almost a 1 ml to a 3 ml syringe. It'll usually have a yellow stopper on top of it, and then it'll be kept in the fridge in the dark all the time. Let's see, that's a quick picture of getting an idea about surface tension. I tried to find a good definition, not the greatest. This is just more of how the surfactant works with trying to keep the alveolar sac open. It also helps to prevent it from over distending, because that can cause a pneumothorax. Has anybody had a chance to help take out chest tubes?
No.
Has anybody seen chest tubes?
It's someone placed.
Okay, saw them placed. That's cool. And they have to. So it was funny because I didn't realize until I saw it placed that they suture in the tubes. Because I thought if the patient moves or coughs, you know, it could slide out. Like, no, it's sutured in. It's not going anywhere. But yeah, it's funny when you have to take them out. Has anybody been with a preceptor who's had to remove the chest tubes before? Yeah, if you have any patients that have chest tubes, you know, ask your preceptors, hey, when are you going to take, if there's any plans for them to come out anytime soon, and just let them know you want to be there when they get taken out. Because even if there might be a chance too where your preceptor doesn't have anybody on their run that has chest tubes, but you can just let them know, hey, we talked about chest tubes. You know, if any other RTs have patients with chest tubes or might be removing them, you know, they could easily, you know, dish you off to the other RTs to get more experience. Like I said, the more you see, the more you do as a student, by the time you guys are out there on your own, you'll be ready for anything. So surfactant replacement therapy, so indications. So we're trying to treat or prevent respiratory distress syndrome in infants. That in itself is one indication for surfactant replacement. And then a completely different reason would be premature delivery. So before 34-week gestation period, we might want to give a baby some surfactant because they have immature type 2 pneumocytes. And this was the ones that we discussed that actually produce surfactant in our bodies. So they have a lack of mature surfactant, and so their bodies and their little lungs aren't functioning as appropriately as needed.
Where do you get the surfactant from? Like, where do they?
I know, so there's one, I think it's like pig produced, this one, Poractin Alpha. But I don't, like I said, different facilities will use different surfactants. You know, they'll have like what their go-to is. And usually, if anything, it's because of cost. They'll go with whichever one is a cheaper cost to the hospital. But like I said, you know, when you guys do your NICU rotations, as familiar as you can be, you know, ask them, hey, what do you guys use? You know, how do you dose it? You know, you could even ask them that, you know, hey, you know, where did I get it? Or you can just Google it. But yeah, I know a lot of replacement stuff is either pig or cow, bovine. If anything is like, you know, you see bovine in the wording, that means it came from a cow. Other reasons for surfactant replacement: meconium aspiration syndrome. Has anybody been around? Okay, I would assume are there anybody in here who doesn't have kids yet? Raise your hand. Oh man, look at Chucky. Okay. How many of you have seen meconium before? I guess that's more thing. Okay. So meconium, if you guys haven't birthed a child yet or done your rotations in the NICU or even in the ED, when they give birth, they have this black tarry substance that's all up in them. That is a meconium. And so when the baby's born, they try to quickly, as fast as they can, hand off the baby to the RT who's responsible so that they can get them suctioned out and so that they can get, the crying is good. You know, when you can hear crying, that's a good indication that the lungs are functioning. There might be some, you know, different levels of how well they're functioning, but crying is always good, sound's always good because they're getting that air flowing. But yeah, meconium, it's everywhere. Like I said, it'll look like a baby came out of like a tar pit. It'll be all over. It can be all over them, but it will be in their lungs. So it needs to get suctioned out. They might poop it or pee it out for a while. Yeah, it's kind of everywhere. But you're trying to get that crap out. Other reasons for surfactant: full-term infants with respiratory distress syndrome, diaphragmatic hernia. I haven't seen that too often. But in any sense, anytime a baby has a condition where they have no to little surfactant or they have low lung volumes. You guys will see I can't remember what it's called, the ventilators for the babies. They don't work like a traditional ventilator you might be used to in the ICU. It's like a,
Vibrating?
Yeah. Yeah, it's like a vibrating, that it's literally providing them with little puffs of air. It's an interesting situation. When you guys kind of go over babies and stuff like that, just be aware that's how they do it. They don't get a traditional ventilator that we're all used to. I don't mind. I prefer working with adults. I can break adults. I have kids, and working around kids made me super sensitive to working around kids, so I preferred being in the ICU. I will admit there are times where there might be openings at your facilities for working in the NICU. Be aware, if you get trained in the NICU and you are like NICU tested and proven, there's a lot of times you'll stay in the NICU. So just something to be aware of, because the more experience and the more things that you're capable of, it allows you to do different things. But because there are so little people who prefer or want to work in the NICU, you know, if that's your thing and that's the direction you want to head, that's perfectly fine. Just be aware that that might be your niche and you get stuck there for maybe longer than you would like. Okay, stuff to consider. Exogenous surfactants, so that's, you know, produced outside of the body. So they can be natural and modified, or they can be synthetically produced. The natural would be like it comes from a pig or a cow. Reasons for giving it, so we can give it as a preventative treatment. So if the doctors and the pediatricians feel like it could help prevent them from going downhill, then they might put in an order and need you guys to administer it. It could also be almost like a last ditch effort as well for signs of distress. Like I said, the hardest thing you might do would be to put a pulse ox on a baby's foot. When you guys have to do ABGs for babies too, anybody had to do ABG on a baby yet? Okay, you're actually going to take your lancet and you're going to get the blood from their foot. They have a lot of blood vessels there. It's annoying, obviously, but that's where you'll get it. You want to get a good sample. So these are some of the drugs of the surfactants. Like I said, each facility will have their own one that they use. So calfactant, baractant, poractant. Like I said, this is one that I saw a lot. I didn't see this other one. There's like another list on there. General techniques of surfactant administration. So this will be your responsibility. Doctor will write an order. Hey, baby A needs some surfactant. So you can either give it intratracheally. You can run it, shimmy it down an ET tube. You definitely want to suction the breathing tube prior to administering the surfactant. You're going to warm it up to room temperature before you administer it. You're going to divide the dose into 4 aliquots. I don't know what that is. I've never heard anybody ever mention that before. Let's just say 4 aliquots is an important thing to know for your quiz. So you will divide your surfactant into 4 aliquots. Go figure. And then once you administer it, when it says turn the baby side to side, you're literally trying to move the baby. You're moving the baby in a manner that you're trying to get that surfactant to move all around their lungs as best as possible. Okay, you're going to watch O2 saturation levels. You're going to watch their work of breathing. You're going to keep an eye out for retractions. All of those different things will help you assess how effective your administration was. Let's see. So there are different ports or breathing tubes or ways that you can use it or administer it. So there's a side port, there's a catheter, and then there's a double lumen ET tube. Here's a picture of it, what it'll roughly look like. When you guys do baby stuff, you'll see these. It's funny because the easiest way to describe surfactant, like it has the consistency of like dishwashing soap. That's kind of what the consistency of it looks like. And in essence, like I said, it's that soapy, filmy kind of feel that helps our lungs to expand and contract appropriately. Some adverse reactions. So when you administer it, the effects can happen quite quickly. So you want to monitor your baby to make sure that. So most of the time, if they have a breathing tube, they're on a ventilator, and now that you administered it, you have to make sure that it wasn't too effective. What I mean is now you're going to have to make adjustments to your vent settings, so your peak pressure, your O2 saturation levels, like hyperinflation, the volume, all of these things can change dramatically after you have administered the surfactant, so just please be aware that these things are going to change, and so you need to make those adjustments as the RT on the vent settings. So yeah, this InfaSurf and CuraSurf. I just know them by their brand names. Those are the two that I saw a lot, pretty often. So chapter summary. So we discussed the function of the mucociliary system, maintaining proper pulmonary hygiene as best as we can. We talked a little bit about the bland aerosols. We want to provide oxygen, but we also want to provide humidity to help. We discussed a little bit about the expectorants and the antitussives. So the expectorants, that was like the guaifenesin, that will thin out the mucus. An antitussive would be like the delsum or dextromethorphan, which helps with the dry hacky cough. And then we talked a little bit about surfactant, how the key goal for the surfactant is to reduce surface tension, which will in essence help prevent the capillaries from collapsing, or the alveoli from collapsing and from them over distending. If we have to provide surfactant, it's to help prevent or treat patients that have complications regarding their surfactant production. Okay, I know it's a lot. If you have questions or concerns, I'll stay after class a little bit. Before you guys head out, we have, I looked at my little list. We have 2 presentations next week. I'm just going to recheck them.
Stay after I talk about breathing for a sec, if you're coming.